You hear the words blood clot in the lungs, and yeah, it sounds terrifying, and for good reason. Today, we're going to crack open the official playbook doctors use to tackle a pulmonary embolism, a condition that's as common as it is dangerous. Let's break down exactly how they fight this silent threat.
So, to put this in perspective, the whole category of problems that includes pulmonary embolism, it's the third most common acute cardiovascular issue on the entire planet. We're talking right behind heart attacks and strokes. So yeah, this is not some rare, obscure thing. It's a huge deal in global health.
Okay, so what is a pulmonary embolism, or PE as you'll hear it called? Well, in the simplest terms, it's a blockage. Usually a blood clot forms in the deep veins of the legs, then it breaks free, travels through your bloodstream, and bam, it gets stuck in one of the arteries in your lungs.
All right, first up, why is a PE considered such a sudden and silent threat? The answer might actually surprise you.
You know, the best way to really get your head around the danger is to think of it like a major plumbing problem. That clot acts like a sudden dam in the main pipe leading out of the heart's right side. All at once, a massive amount of pressure builds up, putting this incredible, immediate strain on the heart muscle. And here's the kicker. In the really bad cases, it's not the lack of oxygen that's the killer. It's the heart suddenly failing from all that pressure.
Okay, so if this thing is so dangerous, how in the world do doctors find it? Let's step into the ER for a minute and see how this medical detective work actually plays out.
So, picture this. Someone shows up in the ER. They've got this sudden shortness of breath, a sharp pain in their chest. Maybe they even passed out. For the doctors, these are massive red flags that kick off a very specific, very urgent process.
Now, for a patient who's stable, the whole thing is actually super logical. It's a step-by-step process. First up, doctors use a scoring system to figure out the probability. Is a PE likely or not? Then, based on that, they might run a blood test called a D-dimer, which basically sniffs out the chemical leftovers of a clot. And only then, if there's still a strong suspicion, do they move on to something like a CT scan.
Okay, let's talk about this D-dimer test for a second, because it's a real workhorse here. Its superpower is being a rule-out tool. If a patient is considered low risk and their D-dimer test is negative, boom, the doctors can be pretty darn sure there's no clot. The search is over. You can safely rule out a PE, and that's huge.
All right, so let's say the tests come back positive. The CT scan lights up. Yep, there's a clot. Diagnosis confirmed. But, and this is a big but, that's only half the story. The next question is the one that really matters.
See, it's not enough to just say, hey, we found a clot. The real question is, how bad is it right now? This whole process is called risk stratification, and it basically dictates everything that happens next.
And what doctors do is they sort the risk into three main buckets. You've got high risk, which is, a full-blown emergency, the patient's in shock. Then there's intermediate risk, where they're stable, but you can see the heart is really struggling. And finally, low risk. They're stable, and the heart's doing okay, all things considered. And this is probably the most important thing to understand about the whole process. The risk isn't about how big the clot looks on the screen. It's all about how much strain that clot is putting on the heart. A tiny little clot that's causing the heart to fail can be way deadlier than a massive one that the heart is somehow managing to pump around. It's all about the impact. So, once they figured out that risk level, boom, the battle plan just snaps into focus. The treatment is totally customized to how big of a threat the patient is facing in that exact moment.
And you can really see the two different game plans here, right? For a low-risk PE, the goal is basically prevention. You use standard blood thinners to stop any more clots from forming while your body works on the one that's already there. But for a high-risk PE, oh no, that's a completely different story. It's a 5-alarm fire. The goal is to destroy that clot right now with powerful clot-busting drugs or even go in and surgically pull it out.
Okay, so the patient's been treated, the immediate danger is off the table. Woo! But the job isn't done. Now the focus has to shift to what comes next: recovery and long-term health.
Look, surviving something like a PE is a big deal, and it's really just the start of a new phase. The road to recovery, it takes vigilance, and it takes a solid plan for the future.
So the latest guidelines really hammer home the need for a structured follow-up, usually about 3 to 6 months out. And the checklist is pretty clear. First, you got to keep up with the meds to stop another clot. Second, manage any side effects from treatment. Third, you're screening for any long-term issues, like chronic breathing problems. And fourth, you're making sure that switch from hospital care to home care is totally seamless.
So, we've just waded through what amounts to like 60 pages of super dense clinical guidelines. So if we had to just boil it all down, what's the one big takeaway here?
It's pretty simple, really. A pulmonary embolism is a flat-out race against time. And the best way to win that race is with a clear, calm strategy that is laser-focused on one thing: figuring out the patient's individual risk and then acting on it, fast. And to wrap it all up, I think this quote from the guidelines says it best, because it reminds us that behind all the charts and the tests and the science, the most important thing is that partnership between the medical team and an informed patient, working together to make the best decisions possible.